Okay, so guys, welcome to part 3 of fluid resuscitation in pediatrics. Okay, I'm gonna do something like this, and this, and this. Is this gonna make sense? Let's see. So this will be our euvolemic patient. So this is the kiddie who has been losing fluids, be it secondary to vomiting, diarrhea, or the two, or whatever, but is euvolemic. This kiddie, if they are vomiting, if the mother is complaining that the kid is vomiting, let's say vomiting or having diarrhea, or diarrhea and vomiting, those are the most common presenting complaints. So there's nothing to resusc here. The kid is euvolemic, so you won't put up an IV line on this patient. What you will do rather is to take a thorough history and do a thorough examination and try to see the cause of the vomiting. Remember, a baby can vomit, or a kid can vomit. Vomiting, let's talk about vomiting alone, right? Let's talk about vomiting alone. I don't want to really talk about the causes of vomiting because it's a topic on its own. So let's talk about vomiting. Vomiting is very non-specific. It's very non-specific. A baby can vomit because of anything you can think of. So most commonly they vomit because of infections. So think about infections. Otitis media can present as vomiting, which means that's why when a kid is vomiting, you need to look for the source of infection first and rule out an infection before you can think about other things. Obviously, the nature of the vomiting and when does it happen also becomes important. Like vomiting early in the morning, projectile vomiting, those are like more sinister causes of vomiting, right? So, but the most common thing that you're gonna be seeing, ear infection, will be lower respiratory tract infection. Will be, when I say even upper respiratory, like sinusitis, pharyngitis, things like that. Even something as small as UTI does cause them to vomit and have headaches as well. Obviously gastritis, AGE, with lower respiratory infection, pneumonia. Why do they end up vomiting? When what I've realized is that when a kid is having some chest infection like pneumonia, they do produce sputum, but they swallow their sputum, and that sputum, as they swallow it, it goes with those bacteria from the lungs and now start to cause an infection in the stomach. They start to vomit, they get irritated. So most of the time you'll find that as much as the vomiting and the diarrhea is there, they are also coughing as well, And if you don't examine the chest, you will miss out. You'll miss that chest infection. I've seen this a lot, guys. I've seen this a lot. And you know, the mom will come in and say, my baby is vomiting and is having diarrhea. Then when you ask, then they don't say anything. Then you ask, are they coughing? Yes, he's coughing. And then you find that it was the cough that started, and then the vomiting happened later, to show that the focus of the infection is the lungs. So there are other things as well. There are more sinister causes like bowel obstruction and all of that. That's why I said I didn't want to talk about the causes. But yeah, and if they say they have got diarrhea, yes, we know that the most common cause of diarrhea of AGE, let me say, in children is, especially those less than 1 year, is viral infection, and the most common is rotavirus. So and for them it's just fluids, because remember, as we all know, that viral infections are self-limiting. So for them it's just to make sure that they're not dehydrated, and then they won't have any problems. But if the diarrhea now starts to have blood or starts to have mucus, blood mucus, then it can be Shigella, shigellosis. There's another one that I'm forgetting now. Dysentery. So it's dysentery basically. So this is called dysentery. The most common cause is Shigella, shigellosis, and there's this other one that I'm forgetting, another cause. So this is for someone who's euvolemic. So the only thing there is gonna be your oral solution. So if you don't find any cause that needs you to worry about, there are no red flags. The child is drinking, is talking, is fine. There are no other red flags on your examination. Yes, you can do an ABG, which will likely be normal, because if they're euvolemic, it means they've not lost a lot of electrolytes and a lot of fluid. Then you can do your bloods, your FBC, CRP, UNE, and you can discharge them on oral fluids, and just tell the mother how to give the oral fluids and how to mix that, the home solution, how to make that. And then these ones should be fine. And then maybe to come back in 2 days time for blood results, or if the child worsens. That's a euvolemic patient who has got no danger signs. Overhydration is not something that a child can come in with from home. Is when maybe they are euvolemic, and then you give them lots of fluid as a doctor. They come to you and they've got periorbital swelling. They've got periorbital swelling, they've got cough, they are short of breath, they've got crackles. These are basically pulmonary edema signs and symptoms. So it's someone who came in not very dehydrated and then was given lots of fluids, or was euvolemic but was given lots of fluids, or was dehydrated but was given too much fluids. So this is why hydration checks are very important, even when the kid is in the ward, to keep checking, are they overhydrated or are they still dehydrated. Yeah, so let's move on to the other side now. So the only thing that's going to save you there is to give them Lasix, the pulmonary edema, and just encourage them to lose water. Yeah. Okay, now let's come to the to dehydration. And then talk about shock this side. Okay, with dehydration, let's quickly talk about the expected signs and symptoms Okay, we said that with shock, you expect this kiddie to have reduced their consciousness, loss of consciousness. You expect them to be cold and clammy. Their peripheries, they might even be cyanotic. You expect them to have reduced BP. We hardly do BPs for them. Ne? They don't even have a cuff. Maybe in big centers, tertiary hospitals, there are cuffs for the kiddies, but in most places there are no cuffs that fit and then increase the pulse or a very weak pulse if it's a very weak and rapid pulse, and also a severely reduced capillary refill. Guys, I don't want to, I'm not kidding you. I once had a baby like this who was so much in shock that you'd swear that, I mean, the arms, the legs, the neck were just like, the child looked very floppy, like generalized floppiness, if I may say, and the eyes were like so sunken. They were so sunken. The skin tag, I mean, it took a couple of minutes to go back. This kid was like so much in shock. Like we said that with these ones, you want to give them normal saline or Ringer's lactate, but not half TD, and you want to give them 20 mils per kg. That's the bolus that they should be getting. So if this is a 4 kg baby, so 20 mils times 4, which is 80 mils. So they should get this 80 mils over, you should give them over, some say over 2 minutes, and watch what happens. If the child does not respond after 5 minutes, some say 10 minutes, you give another, you repeat. And after you have given this, obviously you have you start also running your half TD, which now will be your, will act as your, this is a fluid, this is a resuscitating fluid. Like we said, there's resuscitation, there's replacement, then there's maintenance. So this is your resus fluid. So its job is just to replenish the depleted intravascular volume. That's its job. After it's done, you stop it, you go to half TD. So you don't continue with it. So, okay, now let's talk about the signs of dehydration, right? I think that's very important. Let's talk about the signs of dehydration. Oh, sorry guys. I'm sure that's gonna look very funny on the video, but what can I do? Okay, what time do we have now? Okay. You know, the issue of the way dehydration is graded, it differs from hospital to hospital and from author to author. And it also depends on the head of the department. What does he or she wants to do? What he or she wants to do in his or her department. So it just depends on that. What book is he or she reading? What article? And all of that. They differ so much. So we said the extreme that we can have in terms of weight loss is shock, and then we can have no dehydration, we can have no dehydration like euvolemia, or we can have dehydration that can be mild, that can be moderate, that can be severe. So there are so many differences. But basically, for someone to be in shock, like we said, reduced loss of consciousness, decreased BP, increased pulse that is weak, it's rapid but weak. What else? And this one will also be anuric. The mom will say, this child has not passed urine today, something like that. And they will be cold and clammy peripheries. And then now, so if you've got one or more of these, okay, let's take this one out and put it here, and also this one, let's leave these ones. Once you have more than one or more of these, that kid is in shock, reduced loss of consciousness or reduced consciousness. That kid is in shock. I don't want to because anuria is not specific for this. Cold and climb is not specific for this. That's why I'm removing it. But you can also have it. You have it here, but you can also have it there. But the ones that are very specific for shock, it's these ones. Because cold and clammy peripheries, you can also find them in severe dehydration as well. And you know, when you are patient with your dehydrated baby, even if you give them small amounts of fluids than you're supposed to, or you underestimate when you calculate, as long as you keep checking, you can still keep giving more and manipulating your fluids up until the child is fine. But committing to underhydration and then you leave that kid for many hours can be disastrous. Okay, so another thing would be, so obviously capillary refill that is more than 3 seconds is there, but you can also find it on this side as well. So then when you've got severe dehydration, it means that you've got 2 or more of the following signs, which will be lethargy. You know, when a kid is lethargic, they're just lying there. They're not reacting to the environment. They're just lying there. Even if they cry, some of them don't even cry. But if they cry, they can't even produce tears. They're just lying there. You can pull them. You can do whatever that you want with them. They're not responding to the environment. Even if you smile, try to crack a joke with them, they're just lethargic. They are so dehydrated that they can't do anything. So that's someone who's lethargic. And also, in other cases, so I mentioned sunken eyes. Sunken eyes. Eyes will be sunken. And then you also have anuria, like I mentioned. You have anuria. And then you also have these ones, you know, when you try and see if they can drink, they can either be unable to drink or they drink poorly. And why is that? You know, when you are sick, especially for the kiddies, when they are sick, swallowing is an exercise, a very big exercise for them. So they are so lethargic, so much that they can't, the muscles that they use to swallow are very tired. They don't have energy. They are so tired. So that's why they have got a difficulty. Even though they might be eager, they might be thirsty, very thirsty, but their body is just failing them. They can't. And then now, and then we've got moderate dehydration, whereby you've got you might also have sunken eyes here, but lesser degree as compared to the other side. And then you might have a child that is very, very thirsty. Very thirsty. When you put a bottle of water in their mouth, they drink that like crazy because their thirst center is so much stimulated, and then their skin tagger is less than 2 seconds. But here the skin tagger is more than 3 seconds. And then you have so you have anuria there as well. The anuria here is a plus minus, so let's not even put it's a plus minus. So, and then you can have someone who's mildly dehydrated. These ones, they are well, they are alert, they are alert, they are responding to the environment, there is no sunken eyes. They are responding to the environment, no sunken eyes, and their skin tagger is normal. Their skin tagger is normal, and they don't drink as much, these ones. They do drink, but they're not very thirsty. They're not very thirsty. So guys, the one of the problems with clinical medicine is that not everything is by the book with clinical medicine. So you need to know all your symptoms of dehydration. And also, when you write your notes, you need to say which symptoms did you pick up. And also, when you say the child is not dehydrated, so which symptoms are not there? They become your important negatives. Like a child with diarrhea or whatever, you say, okay, the eyes were not sunken, the child was not lethargic, the lethargic was reactive to the environment, playing with the mother and smiling. So it's just something, just to give people an idea of how this kid was. So yeah, and I know that you guys are gonna go and read more, and yes, you are gonna see other things that I didn't put here, but this is like the most basic way of approaching. So like we said, these ones you can give them oral fluids, address the cause if you can pick up the cause. Like I said, the most common cause of diarrhea and vomiting is viral infections like rotavirus. So if they've got no infection, obviously you are going to do your ABG, especially these ones. You are going to do your ABG and look at their electrolytes, how they are doing. Are they in and also their what is this, they if they've got some kind of a pH imbalance, acid-base imbalances and all of that. So but with these ones, if there's no reason to keep them in the hospital, then you can discharge them on some people do not like using antibiotics if the temperature is not high, and if you've not found a source of infection. They always want to assume that it's viral infection, so fluids alone should be fine. So it's a plus minus. It depends where you are and what does the person that you work with want. But if there's a high temperature, there's obvious infection, you treat the infection and all of that. Okay, let's talk about who should you admit. I think that's very important. So definitely these ones are not gonna go home. They can't be going home. These ones are the plus minus, This one can go home. So let's talk about who should be admitted. A kid who's not drinking should be admitted, because it means the oral solution that they should be taking at home, they will vomit it. So this is like vomiting. If they continue to vomit, they shouldn't go home. A kid with so it's important to ask the mother if the kid is tolerating or not tolerating. So if he's drinking poorly, let's just put it differently. If he's drinking poorly or is vomiting, you should be, there's no problem if your only reason of admitting is continuous vomiting, because it means that they won't eat at home, they'll lose more weight and get into malnutrition. They won't, even the oral fluids that would have prescribed for them, they won't be taking it. So just admit, like we said, those who are dehydrated and those that are in shock can't go home. And dehydration, we said, moderate to severe. Moderate, the plus minus. Severe, it says definite admission. And then you have, if the kid is showing some features of malnutrition, if they are if they've got malnutrition, because a chronic diarrhea can cause malnutrition. So if a kid comes in, and those who've got malnutrition, they take longer to recover from diarrhea or AGE. So that's why they should be admitted. 2, 3, 4, 4. Okay, and also, if, like we spoke about dysentery, that one should be admitted, because that diarrhea that they're having, it shows that it's bacterial. You don't get dysentery or bloody stools or mucoid stools from viruses. You get it from bacteria. So it means they have a bacterial infection, likely that they will need IV antibiotics. Okay, number 5. And also, if the kid is less than 3 months, admit that one. And also, if the temperature is more than 38, that confirms bacterial infection. And also, if they've got, on top of all of this, they are probably having advanced HIV and AIDS, that's an indication for admitting as well. And if they've also have electrolyte abnormalities on your ABG that you did, I know there are places where there's no ABG. So if they've got and the other things would be your clinical judgment, should you let go or should you keep a kid, but these ones are a definite admission. So okay, so let's meet on part 4, guys. That's a long video.